This MRI accident, like so many other MRI accidents, that they appear rather infrequently, and so the tendency is to think this is hand of God level stuff. These are freak accidents. Nobody could anticipate that this accident might happen, and certainly nobody could have prevented it, and none of those things are true.
We're here because we're curious about medical imaging or have a hunger to learn more. What can we learn from each other, and how should we prepare to tackle the challenges ahead? I'm Chris St. John, and join me today as we rethink imaging, a podcast by Imalogics. Welcome to the show. We're going to circle back to best practices and regulatory stuff as well, but I want to take like a slight little tangent. And first of all, I want to plug Toby's podcast, The Invisible Force, which y'all can find podcast platforms, YouTube, and it's being pushed out through AMP Mini. That's correct?
Yeah, they're carrying it as well.
Beautiful. And so on this show, you are investigating an MRI accident that happened last year, July 2025, on Long Island, which I remember seeing this in the news myself. But obviously, there's going to be some stuff we can't totally get into. But do you mind, for anyone who didn't hear about this incident with the gentleman who was not getting scanned, but he was wearing a very heavy metal chain around his neck and ended up getting pulled into the scanner? Do you mind just telling me like the quick summary of what happened on this incident and just touching on it a little bit?
Sure, absolutely. So the gentleman, Keith McAllister, was accompanying his wife, Adrienne Jones McAllister. She was going for the MRI. She was supposed to have an MRI of her knee. And so she goes to this outpatient imaging center, NASA Open MRI in Nassau County, New York, out on Long Island. So she goes for an MRI. And at the end of the exam, so she's already been sort of pulled out of the tube, out of the donut, and she's laying on the table there. And she calls for her husband. Amazingly, the facility had closed-circuit security cameras that recorded all of the activity throughout the building. And somebody somewhere, I suspect within Nassau PD or DA's office, leaked about 1 minute and 20-second video clip. The camera is just outside the MRI scanner room, and it looks through the open doorway. And so we see Adrienne Jones McAllister on the MRI scanner table. We see the MRI technologist in the room with her. And then we see Mr. McAllister sort of walk in under the camera, walk into frame and go through the open door and go into the MRI scanner room on the opposite side of the table from where the MRI technologist is. So he's there. He's helping his wife sit up in the mag. So she's laying on her back and she reaches out her hands to him. He reaches out his hands to her. They grab hold of one another, and then he's pulling her up into a seated position, which makes her torso kind of come close to him. So he takes a step backwards as she comes up into a seated position. And that little half step backwards is enough to get this 20-pound chain that's around his neck. Some people may wear like weighted vests or rucksacks or something like that for improved cardio workout. This appeared to be just sort of a more, I don't know what the right word is, a utilitarian version of a rucksack or a weighted vest. This was just sort of a weighted chain around his neck. That half step that he takes pulling his wife up into a seated position is enough to get the chain right within the super high strength magnetic field part of the MRI. Watching the video, it's not gory, but it is certainly disconcerting. All of a sudden, you see this man, with like an invisible rope around his neck that essentially pulls him by the chain, pulls the chain, which is around his neck, and pulls him headfirst into the tube of the MRI scanner. And the video clip ends very shortly thereafter. The technologist is reaching in, trying to pull the chain off of around his neck, and Mrs. Jones McAllister is grabbing his belt and trying to pull him out by his belt. The video stops. After an extended period of time, identified by Mrs. Jones McAllister as being, the better part of an hour in order to get him out of the tube. So he's in the tube with a steel chain around his neck for the better part of an hour. They are ultimately able to get him out, and they rush him to nearby University Hospital, but he is pronounced dead the following day, purportedly having died after having suffered multiple heart attacks. And this MRI accident, like so many other MRI accidents, that they appear rather infrequently. And so the tendency is to think this is hand of God level stuff. These are freak accidents. Nobody could anticipate, that this accident might happen. And certainly nobody could have prevented it. And none of those things are true. There is a long and storied history of people going into MRI scanner rooms with things that are magnetic and get pulled to the MRI and have caused injuries or deaths. State of New York actually now owns the two most infamous MRI deaths in the United States, both of which are magnetic objects getting pulled at the MRI scanner. The first one, when we were talking about sort of my architectural introduction into MRI safety, I talked about the 2002 ACR white paper on MR safety. That was written in direct response to the death of Michael Colombini at Westchester Medical Center, which happened in the summer of 2001. And 24 years later, also in New York, we have Mr. Keith McAllister, who dies because of the chain around his neck. So we have a long and storied history of these kinds of accidents happening, projectile accidents in particular, because they tend to be kind of photogenic. But despite the fact that we know how they happen, despite the fact that we have built a body of preventions, if we actually followed them, they'd be really effective at stopping these. Nobody requires them.
Beautiful. So you were saying that it took them about an hour to get him out of the MRI, which, from my limited understanding of how MRIs work, there's a quench button, which uses liquid helium to rapidly cool the what? The coil, the magnet?
So we rapidly boil off the liquid helium that keeps the magnet cold. So when the wire that makes the magnetic field is 450 degrees below zero, it becomes superconducting, which means you put electricity into it once and it stores it like a battery while it keeps making a magnetic field. And if you shut off the power to the entire city block, it does nothing to the magnetic field because it's stored like a battery. The energy to make the magnetic field is stored like a battery in the wires. So we have to have another way of turning off the magnetic field, which is what the quench button is. So the quench button, essentially you push that button, it activates a little heater inside the MRI scanner, and it starts a cascade effect that winds up boiling off all the liquid helium. And now the wire inside the MRI scanner, it converts the electrical energy that makes the magnetic field, it converts that into heat to boil off the helium. So it's a big deal to push that button. And the original conjecture, inferences made by folks related to the imaging center, was that they pushed the big red button that's supposed to trigger the quench, that's supposed to make the magnetic field go away. And for whatever reason, it didn't work. Even to the point where they wound up putting in an emergent call to contracted service engineering company to dispatch somebody to figure out why the quench button wasn't working while they were exploring other ways of trying to get Mr. McAllister out of the tube. In an interview, the MRI tech, or conversation between the MRI tech and some other folks who I spoke with, so this is secondhand, but sources I rely upon and have a great deal of faith on, apparently the MRI tech described the act of hitting the quench button, and the quench button didn't work, and the other folks were sort of exploring that. And he said, yeah, I went up to the face of the bore of the magnet and I hit the red button. In many MRI scanners, there is a red button on the face of the MRI, but it's not the quench button. It's what's called an e-stop button. And essentially, if there is an imaging sequence running at the moment, hitting the e-stop button stops the pulse sequence from running and unlocks the table so you could just slide the patient out. Now, at the moment that he pushed this button, there was no sequence running, and Mrs. McAllister was already slid out of the tube. So if you hit that button, nothing noticeable would happen. So if the technologist was under the impression that that was the quench button and he kept poking that button and nothing happened, one would understand how he would have the impression that quench button was broken, that it wasn't working. The fact that neither the imaging equipment service company nor the manufacturer of the MRI scanner were named in any of the subsequent lawsuits is a good indication that there wasn't anything identified wrong with the Quench Button. This appears to have been entirely an issue of operator error.
Yeah. It gets me thinking, about like the crux of this conversation, right? What does this say about the state of MRI safety in general within the US, right? Part of me instinctually is just like, how are these buttons not better labeled? And not to boil it down to something so simple, but something as simple as labeling, but also like an MRI tech, I understand like it's a very scary situation. And I understand that the way that the human brain and the human body responds in traumatic situations, like you're not always thinking clearly, of course. And so I'm not trying to dismiss whatever situation that tech was going through, but at the same time, it seems like if someone was to be approved to be an MRI tech, the Quench Button seems to be a core safety principle that needs to be like deeply embedded into their brain and into their practice to some degree.
I'll give you a couple of disturbing examples of where we stand with MRI safety education. One of those is did a seminar this past weekend and was talking with somebody who had done a deep dive into the ARRT, the American Registry of Radiologic Technologists, their certification exam for MR credential, so RTMRs. In order to pass the registry exam, you have to get a certain number of the total presented questions correct. I guess you're allowed to miss, I'm making up the numbers here because I don't know specifically what they are. Let's say you're allowed to miss 25% of all of the presented questions. Well, if the safety questions presented on an exam are 10% of the questions, you can essentially blow all of the safety content and still get your registry assigned for RTMR. That's actually a better situation than radiologists. So radiologists are, for the radiologists who are listening right now, don't blame the messenger, radiologists are legally responsible for the safe execution of the exam. That's not something that gets talked about very frequently. Quality, accuracy, timeliness of reporting is usually what gets emphasized in terms of a radiologist's legal duty. But in addition to those, radiologists are the supervising physicians for MRI exams. In a radiology residency, radiologists are required to get radiation safety training. They are not required to get any MRI safety training. So you can have a radiologist, the MD who is in charge of the safety of the execution of the exam, who has completed their registry and has not the first clue about MRI safety. That's the state of art in 2026. To be clear, there are radiology residency programs, and I actually teach MRI safety for at least one of them, where we make sure that we're introducing this important knowledge for the radiology residents. But a program that was only looking to do the checkbox minimums of what the ACGME says they have to, you can turn out radiology residents who have no knowledge of MRI safety. And board certification in radiology is kind of similar to the situation that we described for the RTMR registration. You can bomb all of the MRI safety questions and still pass a board registry. So we don't have effective MRI safety training minimums, even for the people who have the most hands-on responsibility for the safety of patients and the environment.
Do you think it should be the federal government, state governments, accrediting bodies? Like, where do you see these safety pathways as needing to come from?
I think, like most people, I have a skepticism about the federal government sweeping in to make our lives better. That being said, we've been living with a choose your own adventure model for MRI safety. And we keep seeing people injured in ways that we know how those injuries happen, and we know we have effective preventions. So like many people in radiology for a long time, I thought, we will be good and self-police and, we'll get this stuff done. That has not happened in the last 25 years. And in fact, as MRI care gets more and more complicated, the situation appears to be getting progressively worse. So at this point, I'm thinking, yeah, we need to have somebody step in. And I think that there are a few different ways that that could happen. CMS, 800-pound gorilla in the healthcare space, if they so chose. So there is, on the hospital side, CMS has conditions of participation. And one of the things that the radiology conditions of participation say is that you must meet professionally approved standards for safety. Now, if you go to CMS, as I have done, and knock on their door and say, hey, you say we must meet professionally approved standards for safety, I'm not going to ask you for all of healthcare. I'm just going to ask you for one area, for MRI. What do you acknowledge as the professionally approved standards for MRI safety? If you go and do that, CMS essentially sort of throws up their hands and go, we don't know. Surely the world out there knows what those standards are, right? Go ask the states, because we, CMS, we don't actually enforce this at like a national level. It's the states who enforce this on our behalf. Go ask the states. So this was motivated by one particular accident that had happened in the state of Texas. So I went and asked Texas Department of Health. That's not what it's called. I can't remember exactly what the title of the department is, but I went and asked them, and they essentially said, why are you asking the states what CMS's must meet professional approved standard is? If it's a CMS requirement for professionally approved standards, then you should be asking CMS. I said, yeah, but CMS said, you guys are the enforcers. You guys would know. And they're like, why would we know? It's a CMS standard. We're the hired muscle. We're supposed to do what they say. If they don't tell us what it is, we're not going to do anything. So CMS could change the MRI safety landscape with a snap of their fingers if they just said, hey, guys, for MRI safety, when we talk about professionally approved standards, what we mean is today, we reserve the right to change our mind tomorrow, but today, what we mean is the ACR manual on MR safety. If they did that, now all of a sudden there is an objective best practice set of criteria that are now invoked and referenced on sort of a national scale. They could similarly do that if they didn't want to do that sort of publicly to all of the providers or to all of the states. They could go to the accreditation organizations and they could say, hey, we're seeing a disconcerting growth in MRI accidents. We want all of you guys to show us how you are incorporating the specific performance criteria that appear in this ACR document. And again, that would have sea change level impact on the hospitals. In 2008, the U.S. federal government passed MIPA legislation. And I can't remember exactly what the acronym stands for, but it's medical imaging. And in the MIPA legislation, they essentially said CMS will pay for CT scans, PET scans, and MRI scans from outpatient facilities, outpatient providers. And those services are supposed to be provided safely and effectively. Now, the first two of those, CT scans and PET scans, use ionizing radiation. So there is a body of both state and federal safety standards associated with it. But there are no state or federal standards for MRI safety. So despite the fact that on outpatient imaging side, MIPA says you must do this safely and effectively, there's no yardstick. There's no measurement tool for the safety of providing MRI services. If CMS wanted to, like I say, they could snap their fingers and they could change the MRI safety landscape overnight simply by identifying what tools we should be referencing where there are specifically explicitly invoked, references. If they just told us, hey, this is what we want you to use, the world would change overnight, and we wouldn't need to depend on our senators and representatives and their policy aides and the lobbyists all swooping in to try and craft something that was suited them better. We have a really brilliant set of MRI safety best practice standards that is out there, that's publicly, freely available, that is the most comprehensive thing that I have seen from anywhere around the world. And yet, it languishes in this status of, hey, guys, we think it would be a good idea. We'd really like it if, nobody is saying, you know what, we demand safe patient care. And there are specific performance criteria that will help you get safe patient care. And therefore, we expect you to be following these criteria. We're not there. The criteria exist. Just nobody so far has been willing to say, these are the ones we want you to use.
Also, at the same time, didn't CMS also recently release new CPT codes for reimbursement for doing proper implant screening or something?
This, in my mind, just absolutely takes the cake in terms of, sort of making the case for MRI safety standards. So because of the increasing complexity of MRI and MRI safety, because we have patients in whom there are greater numbers and varieties and complications related to implants, devices, and foreign bodies, CMS has justifiably, in my mind, said, you know what, the folks who are doing these more complicated patients, we actually need to compensate them for the additional labor associated with more complex patient care, which I think is both appropriate and the responsible thing to do so we don't financially penalize the institutions that take care of our more complicated patients. I think it's brilliant. I absolutely love the fact that CMS has the CPT codes. If MRI safety is so much more complicated today than it was 20 years ago, so much so that we need additional reimbursement tools. Who actually is implementing these reimbursement tools, right? So we have the technologists and we have the radiologists who we don't require any meaningful MRI safety training as sort of basic foundational layer to the whole system. So we're willing to pay for more complicated MRI patient care, but CMS at the same time is unwilling or unable to essentially establish some minimum safety standards for the people or for the practices that are going on inside these imaging centers. I would not want CMS to throw the baby out with the bathwater here. And I wouldn't want them to undo anything related to the CPT codes because they are definitely a step in the right direction. But they acknowledge the complexity of the safety situation in MRI in a way that CMS fails to acknowledge when it comes to what are the minimum standards for policies and procedures and actions and minimum training. So yes, I think that these facilities should get paid for the additional work that they're doing. But if the entire rationale for paying them more is MRI is more dangerous and more complicated and more labor intensive, shouldn't we also be looking at these other pieces of it? So thumbs up to the CPT codes, but where the hell is CMS with respect to addressing some of the underlying issues that the CPT codes are trying to correct?
You've also written about how MRI remote scanning and how safety standards haven't kept up with the technology itself. I'm curious, what's the risk there and what should facilities be thinking about?
So remote scanning is really interesting. It pushes a lot of people's buttons, and a lot of people have sort of immediate reactions to just the idea that the person who's running the scanner isn't there. Right? High-speed internet connection, they can run the scanner from Timbuktu.
Can they press the Quench button from Timbuktu?
Well, that's one of the problems, is a lot of the risks. So the three things that we identified, burns, projectiles, and hearing damage. Those things are managed as pieces of the physical environment, right? And if the technologist who's running the MRI scanner is no longer a part of that physical environment, who's responsible for it? So interestingly, in the ACR safety document that I keep on hoisting up onto a pedestal, one of the things that I disagreed with in the 2024 ACR manual was when they addressed, and it was a very sort of perfunctory addressing of remote scanning from a safety standpoint, they essentially said, hey, look, there's really only one existing role or credential that is recognized between and among the states and the feds and whatnot that we have some degree of confidence that they understand the MRI environment and the safety of working inside that environment. And that role is the RTMR, the MR subspecialty certified technologist. So if we want somebody who's running the MRI scanner, we want that to be an RTMR. And if we want somebody who's in charge of the physical environment and patient screening and prep and positioning and coil selection and padding of the patient, the only person that we know that gets that kind of training is an RTMR. So we want an RTMR in that place, which ignores some of sort of the fundamental labor shortage issues, some of the fundamental economics that are pushing for remote scanning. So we, in many, many parts of the United States, we don't have one RTMR per magnet. And so the ACR's minimum staffing is one in a fraction, the one who's there, and then the remote rad tech may be running 2 scanners or 3 scanners concurrently interleaved. So their response kind of failed, in my estimation, on 2 counts. One, it ignored the underlying labor and economic reasons for remote scanning. And number 2, it sort of failed in terms of imagination. Yes, in fact, I would agree that at the time when the 2024 document was written, the only individuals that we count on to have that kind of knowledge and training are MR rad techs. So why don't we describe how we impart that knowledge to folks who aren't MR rad techs? And that piece of it, we're now seeing ARRT, beginning of the year, announced this new imaging assistant role, IAMR, and that they're going to essentially have a registry for these individuals sometime late summer or fall, which is brilliant. Interestingly, the IAMRs, the essentially tech aid for MR, those people are going to have more MR safety training than rad techs, than MR techs. The continuing education requirements for the IAMRs is going to be, from an MRI safety standpoint, the tech aides are going to have more MRI safety continuing education than the RTMRs. So we're beginning to see, I think, sort of a recognition of, oh, you know what, this physical environment management piece of this is really important, to the point where they're requiring more MR safety training for the tech aides than for the techs themselves. So we are beginning to see the development of roles and infrastructure that can support remote scanning and still help provide assurances of effective management of the safety environment. Knowing which button is the right quench button. These kinds of things are exceptionally important when you need them.
I want to talk about a quote from you where you say, if you've been told MRI safety only comes at the expense of throughput, you have been lied to. Will you make that case for me?
Sure. This actually kind of brings things around full circle to some extent. And it has to do with sort of the workflow and our understanding and sort of conscious awareness of, did we choose to do this, or have we just kind of fallen into doing things this way? A number of years ago, I ran a poll on the Facebook MRI safety group. And right now we're just shy of like 40,000 people from around the world who participate in it. So decent numbers of folks. I ran a poll and I asked folks, how many patient slots, schedule windows, get left empty because patients show up at the doorstep and, did I forget to tell you that I have a pacemaker? Or, yeah, no, I had some kind of surgery for my stroke, but I don't know what they did. These sort of 11th hour surprises related to patient safety and the number of appointment slots that get left open because of the 11th hour surprises. And I think the average was around like 2.5 appointment slots per tech, so we're assuming a 40-hour work week. Now, most magnets are going to be running more than that. So multiply it times the working hours of the MRI at the hospital or the imaging center. But it was 2.5 2.5 appointment slots on average. And as you got into like academic medical centers, that number went up to, approaching 5 appointment slots per full-time shift per magnet. And what I think most facilities don't realize is that in many instances, if we were smarter about our process, we could identify what those risks are, and those patients either would be outright canceled, right? No, I'm sorry, we can't do you with that particular implant or foreign body or whatever, and we're going to schedule somebody else in that slot. Or we can identify and resolve whatever the potential conflicts are, and that patient is good to go forward with their study. Let's say the average is two patients per week. And let's cut off probably what folks' average technical revenue per MR study is. Let's, again, make the math easy. We'll say it's $500 per study that's done. So that's $1,000 a week per 40 hours working of the magnet. So that's $52,000 a year. And that assumes that you're only running your imaging center, 9 to 5, Monday through Friday. So let's just give 50% more than that. Let's say, we're at like $75,000, $80,000. An individual facility is probably losing at a minimum $75,000, $80,000 because they are not managing MR safety screening patient clearance processes very efficiently. Let's assume that we're still going to get some 11th hour surprises, right? We can improve processes and we're always going to get surprised. Let's just take half of that. I can put $40,000 a year in the pocket of a single magnet MRI operator who only works Monday through Saturday. And we can do this by improving the ways that we manage patient scheduling, patient screening, by making the people at the point of care more intelligent about assessing the risks, by working with the radiologists and identifying clinical decision support tools so that we have more uniformity of care. What a lot of facilities don't realize is that one of the number one drags on productivity and throughput is their inefficient way at managing the safety-related questions. And if we improve the workflow as it pertains to safety, one of the expected outcomes is you're going to scan more patients in a day, a week, a month, a quarter, a year. You're going to scan more people. You're going to collect more revenue. And you're likely to do it with less uncompensated labor. We talked about the CPT codes, and now there are some compensations associated with that. But if we can just avoid those bottlenecks and those speed bumps associated with patients, you can maximize the most, revenue generating part of your practice, which is getting people into and out of that scanner. And so the notion that the resistance that I have seen some radiology administrators and C-suite people about, God, this guy's going to come in and talk about MRI safety, and that means he's going to want to slow everything down and we're going to do fewer patients. I'm very pleased to report that a lot of those people are pleasantly surprised that, no, in fact, I don't want you to slow down unnecessarily. That there are certain situations where that's probably appropriate. But for the most part, I want you to speed up. I want you to do better in terms of managing the things that are these speed bumps that will allow you to have a more frictionless patient experience and more frictionless sort of patient throughput on a daily basis.
I feel like that's like a beautiful full circle moment to kind of wrap things up. Toby, that is all the time we have today, but thank you so much for coming on the show. I have loved talking to you today.
Well, thank you very much. The pleasure has been mine. Love your podcast. I love all of the guests that you've brought on, and I hope I live up to expectations.
Thank you. I'm sure you will. I hope to have you back someday.
Thank you.
Rethink Imaging is brought to you by Imalogics. Here, you'll find engaging interviews with thought leaders, experts, and patients, sharing stories that showcase the transformative power of medical imaging. To discover how Imalogics is rethinking imaging in healthcare, visit imalogics.com. Be sure to subscribe to Rethink Imaging on Apple Podcasts, Spotify, or wherever you listen. And from all of us here at Imalogics, thanks for tuning in.